and share the screen. Okay. Can you guys see this?
We see your bookshelf.
Oh, all right. Okay. Hold on. You see that, right? Yes. Right?
Yes.
Okay. All right. Sorry about that. Okay. We're going to talk about, this is going to be very short because there's a whole lot of information on this handout, but I'm not going to hold you responsible for all of it because you will get it again next year. So we'll just talk about things like what type of fractures there are and what the complications associated with fractures would be. So a transverse fracture is a fracture that is perpendicular through the long axis of the bone. So it's transverse, 90 degrees. An oblique fracture is at an angle, like it says, oblique. And as the angle increases, it becomes a spiral fracture. Spiral fractures are usually a result of something that's torsional, and it can be with weight bearing, it can be without weight bearing, or it can be with a longitudinal pull. So, such as a spiral fracture may be also associated with child abuse. And not, I'm not saying it is 100% of the time, but if a child came into the ER with multiple spiral fractures, it's a torsional injury. So on a long growing bone. So if they were yanked at the arm, you could have a spiral fracture. So that's a torsional injury. Comminuted fracture is when there's more than two fragments, proximal and a distal. And non, excuse me one second. I just want to hold on. Good morning, Essex County College PTA program. I'm in class. Okay. All right. Bye. I'm sorry. Comminuted fracture only has two fragments. Comminuted many fragments. So comminuted fracture may occur with somebody jumping jumping from or falling from a tree, and multiple fractures occur. Displaced fracture is when the fragments lose their natural alignment, and non-displaced is a relative position of the fragments is maintained. A lot of times with a non-displaced fracture, what they could do is just they could put it together. They do a little traction, put it together. Look at this in the ER. Yes, in the ER. Take an X-ray of it, cast it, and you'll be okay. Displaced fracture is going to require surgical intervention. An avulsion fracture is when you have a piece of bone that's pulled off with soft tissue attachment. I think last semester we talked about and correct me if I'm wrong, but I believe that I mentioned a pseudo-Jones fracture to you last semester. Pseudo-Jones fracture is one that occurs when the peroneus brevis, through a violent eversion or inversion sprain, um, an inversion sprain, you have the peroneus brevis that is pulled off the lateral aspect of the fifth metatarsal, because that's where it inserts. And if part of the bone comes off of it, that is known as an avulsion fracture. Okay. So let's see. Intra-articular, the joint surface is interrupted and involves the articular cartilage, and that needs to be reduced properly. A stress fracture occurs and it's associated with an overuse injury. So one of the things is remember I talked about a stress fracture. Some people come in with stress fractures of the tibia after running or changing their running terrain, or not stretching appropriately, and maybe their shoes are wear down, or maybe they're running the same angle, the same pattern every day, and they develop a stress fracture because it's repeated overuse. And that fracture is usually not seen initially because it's a slight fracture, and then over then over time you see callus formation on the x-ray, but this person will go into their doctor and say, you know, my shin hurts or something like that, and I've been increasing my running regimen, and the doctor would say, you know, we recommend you to stay off this leg and to do some NSAIDs to take care of it. And then but if like a typical runner, if people continue to run, they'll have more and more pain and they won't be able to, and they may show up in a physician's office a few weeks later, and you'll notice that there's some callus formation that's associated with stress fracture. Pathological fracture is the result of abnormal disease process, and the fracture is considered abnormal. So we talked about the fractures associated with osteoporosis, or even if you have something known as osteomyelitis. We talked about osteomyelitis in the last lecture or 2 lectures ago, and we said osteomyelitis was an bone infection. So if you have a pathological fracture, it's a result of some kind of an abnormal disease. And finally, a Colles fracture is distal end. Remember, we talked about that last semester, distal end fracture, and it's associated with fork tine or dinner fork deformity. So it's 2 centimeters above the wrist, and you have a dorsal displacement of the radius. Okay. Open fracture is when the bone comes through the skin, and the thing you worry about with an open fracture is the risk of infection. So if you see a fracture, you're with someone who has a fracture and they have a compound open fracture, the thing you do is keep it clean and get the person to the ER as soon as possible. But you're not going to take the bone and try to push it in, because anything that's open fracture or compound fracture is associated with infections. So you could also have delayed unions or malunions with these fractures. Closed fractures is when there's no break in the skin, and a dislocation is a complete loss of the contact of the two articular surfaces, which is different than a subluxation. Because the subluxation, the congruity, partial loss of the congruity, but it's still in the capsule itself. Ligaments are still intact. It's just that we have there's the relationship of the joint is still there. However, subluxation is associated with some weakness as opposed to actually a disruption of ligaments. So here's some types of fractures. Avulsion fracture, remember I said this would be a type of avulsion fracture, a violent inversion sprain. You might see an avulsion of the fifth metatarsal. You could have an avulsion anywhere though. So here's you have a fracture here, and you may have an avulsion of ligaments on the bone here. And here's other fractures. Epiphyseal fracture. So what do we worry about with an epiphyseal fracture on a growing bone? You worry about the growth spurt. Comminuted fracture, many pieces. Compression fracture is when we talked about that last semester also. Compression fracture is when the two bones approximate, or more than two bones approximate. Green stick fracture, we said that last semester too. A green stick fracture is not associated with, it's not called a complete fracture. Remember we said it's something like a twig. If you bend it, it breaks on one side, and the integrity is maintained on the other side. So this is associated green stick fractures you see in children. Impacted fractures, oblique fractures, transverse fractures, stress fractures. You could see stress fracture on a weight-bearing surface. You could see a stress fracture on the tibia. Spiral fracture, again, associated with possible child abuse. We're not going to talk about the fracture reductions. You could look through that. I'm not going to hold you responsible for it. All right. Fracture treatment. Let's see, skeletal traction. They very rarely do skeletal traction anymore because they have to keep a child or an adult in bed for a very long time. So that traction can be fixed to the end of the bed, and it's balanced with weights and pulleys. Remember, we talked about Thomas splint and a traction. But generally, they try not to do that. What is the most important thing? That's what we would talk about here when anytime we have pins in, if somebody has a traction device for pins or an X-fix, external fixation, most important thing we're going to worry about is the pin track infection. So we're going to make sure that's clean. Okay, open reduction, tractions are fixed with screws, lags, compressive devices, pins, nailing, anything that they have to stabilize the fracture, they will. All right, so complications. There's soft tissue complications, which include anything like hemorrhaging, edema, tissue death, muscle contusions. Vascular complications are arterial, as well as venous complications. So if we look at the vascular complications and we look at arterial spasms, you could have a thrombus or a thrombosis. So a spasm from sudden severe traction results in an occlusion. So that occlusion can result in a thrombosis. So we have to be concerned that a patient, what the patient tells us regarding edema in their lower extremity or pain, discomfort, redness, etc. So arterial compression, arterioles can be caught between the fragments themselves, or it can just be secondary to edema. So the edema around the soft tissue can cause arterial compressions. So this thrombosis is this narrowing of the, with arterial sclerosis, we have a narrowing of the vessel walls. Arterial occlusion signs are pallor, so it becomes white, decreased pulse. All these things are associated with arterial wounds, decreased pulse, cooled extremities that become mottled. So mottled is that red and whiteness. Any kind of arterial occlusion can lead to gangrene, and gangrene can lead to tissue death, a necrosis, and then resulted in amputation. Glenohumeral dislocations can result in axillary nerve damage and compression. So if we have a glenohumeral dislocation, most dislocations in the glenohumeral joint occur anteriorly. And if we have damage to the axillary nerve, then anything innervated by the axillary nerve we can have weakness, and we can also have loss of function. So what's the biggest thing associated with damage to the axillary nerve? Axillary nerve innervates what? Well, I can't ask you right now because you guys can't answer me, but one of the big things the axillary nerve innervates is the deltoid, right? And the deltoid is your primary abductor, so you could loss of abduction. Mid-shaft humeral fractures will also result in radial nerve damage. So if you have radial nerve damage, then you'll wind up with hand deformity, which would be wrist drops, and all your extensors would be affected. Elbow dislocations can result in ulnar nerve damage. So ulnar nerve damage is going to result in problems with grip. Remember that. Your grip strength, and the ulnar nerve innervates your flexors as well as the intrinsics of the hand. The distal radius and carpal bone dislocations impede on the median nerve. So the median nerve, we're going to have problems associated with, again, gripping, pronation, etc. And different things on the thumb, median nerve associated with when we talked about benediction sign, etc. And ulnar nerve associated with thumb adduction. Pelvic fractures can cause compression on the lumbosacral roots and as well as the sciatic nerve. So the sciatic nerve is the largest nerve in the body, and splitting into the popliteal, at the popliteal space, splitting into the tibial as well as the common peroneal. So the entire leg can be affected. And femoral dislocations involve the sciatic nerve also. Proximal fibular fractures are associated with the common peroneal nerve, and the common peroneal nerve, we know, splits into the deep and the superficial and can result in foot drop, which is really important during gait, right? So what part of the gait cycle is that important in? Several parts, right? The initial contact and load response, where the foot has to be lowered to the floor, as well as the swing phase of gait. Compartment syndromes. A compartment syndrome is associated with an excess amount of pressure that's built up inside a space, the enclosed space. So this enclosed space where the pressure is built up will impede blood flow. If you see Volkmann's ischemia, or sometimes there's Volkmann's contracture associated with Volkmann's ischemia, this is generally seen in the forearm, and the tissue pressure will exceed the capillary pressure. Most often, due to a fracture, it'll cause bleeding in the muscle, and you'll have an increased pressure on the nerves. So, hemorrhage, muscle hypertrophy, ischemia, burns, venous obstruction, restructure dressing. Signs and symptoms: the person will complain of severe pain, white, cool skin, edema, the inability to feel, difficulty feeling, as well as paralysis. So Volkmann's ischemia is generally in the elbow. But you could also have a compartment syndrome, just a plain compartment syndrome. And I think we talked about this again. A compartment syndrome is when we have that excess pressure buildup. So maybe some kind of a crush injury or maybe a cast that's too tight. And a compartment syndrome in the lower extremity is often seen where they would have to do a fasciotomy. So if they do a fasciotomy, it's a surgical procedure where they cut the fascia to release the pressure on the tissues and increase circulation. Okay, so compartment syndrome. This is one type of compartment syndrome, Volkmann's ischemia in the elbow, but there are compartment syndromes that occur in the lower extremity. Venous complications, venous thrombosis, pulmonary embolism. So with thrombosis, we can release, thrombus can be released and cause into the circulatory system and become pulmonary embolism. Okay. Bony complications, avascular necrosis. Avascular necrosis is tissue death, so it's usually damage to the nutrients. You could also see degenerative, delayed union of the limb. Delayed union means that it takes longer to heal, longer than usual to heal. Whereas a malunion is a fracture that heals, but then it heals in an unsatisfactory position. I think I told you guys that the reason why I had to have a knee replacement was because I had a malunion of a femur, which I had no idea that I had, but I was ambulating on a malunion for many years. Delayed union healing at a much slower than normal rate, and sometimes they have to do a bone graft or they use calcium stimulators. And a non-union is a complete failure of a fracture to unite after a specific time. You could have a fibrous non-union. A fibrous connection is made between the bones. They'll have to do autograft or so a self-graft of a bone on someone's bone. Use one bone or part of a bone and they transfer it to the other bone to provide a union between those. Pseudoarthrosis is a false joint. That's usually a non-union. It comes from a non-union. There's lack of fusion. There's an abnormal union. So the continuous movement at the fracture site can cause a false joint. And that false joint can include a synovial fluid cavity and capsule. Other problems: infections, osteomyelitis, difficult to control, very resistant to treatment. These people need to be on antibiotics, and usually you get them in on IV antibiotics ASAP. Reflex sympathetic dystrophy, we talked about, I believe, last semester. It's under the umbrella of a complex regional pain syndrome. So these patients can manifest the symptoms or clinical symptoms are all over the place. These people can have diffuse diaphoresis, they can have paresthesias, they can have dysesthesia, they can have hyperesthesia, they can have swelling, they can have a numerous amount of symptoms. Post-traumatic osteoporosis, disuse atrophy of bone. Remember we said that bone resorption exceeds a deposition, especially if their muscle tone isn't maintained. Could also have a refracture, especially around implants, a refracture of the site. And if we have a refracture, we have if we have implants and we have a refracture, the surgeon has to go in and if it is associated with a total hip or total knee replacement, that total hip or total knee would have to be replaced also. Metal failure, usually where there's a non-union or delayed union, the repeated stress on the metal for months or years could start to break down and causing the metal to fail and break. Generally today with titanium and everything, people don't have uh, so much failure in the joints. However, you can have an infection or the body can reject it. Myositis ossificans is usually in the thigh or the elbow. It's associated with a hematoma. It's hematoma in the muscle tissue, and as that you have that hematoma in the muscle tissue, it'll start to ossify. The fascia will start to ossify, so it'll feel hard, as opposed to heterotopic ossification. Heterotopic ossification is associated with abnormal growth of the bone in non-skeletal tissue, and the bone usually grows at 3 times the normal rate, and usually is absorbed within 6 to 12-month period. But you could have heterotopic ossification, and the treatment for it is heat, ultrasound, exercises. Immobilization is important. Contraindications are massage, passive range of motion, and resisted range of motion. So those are heterotopic ossification. Also sometimes occurs after hip replacements, and they usually do radiation after them. We'll have to ask Professor D'Onofrio if he got. My mom actually had heterotopic ossification, and in her instance, it was a good thing because she fractured after the hip replacement, and after they went in and redid the hip, the ossification actually made the leg more stable. However, you see heterotopic ossification. You may see it also in fractures of people who are paraplegics, and they have heterotopic ossification, which becomes reabsorbed over the 12-month period. Okay, we talked about stress fractures, and the treatment would be to allow the healing and eventually work this person back into some kind of an exercise program. Okay, so that's this. It's pretty quick, but it's just, they're just facts. So now we'll go into goniometry. So what is goniometry? It's measurement of a joint angle. That's the definition of goniometry. And range of motion is an arc of motion that occurs at a joint, series of joints, and we have passive, active assisted range of motion. Active range of motion is what the patient does. Active assisted range of motion is when the patient needs assistance.
Dr. Stutz,
Yes.
Can you change your screen?
Change the screen?
Yeah, because we don't see the goniometry.
Oh, really? It says I'm sharing.
No, we don't see anything.
All right. Okay, hold on. All right, hold on. I'll go back to here. Hold on. Huh. All right. Let me just. Okay.
Professor, you're sharing your screen, but oh, there it is.
How about now? Can you see it now?
Yes.
Can you? Yeah? Okay.
Yep.
All right. So active range of motion is when the person does the motion. Active assist is when there needs to be some assistance, whether it's from another person or whether it's from a machine. And passive range of motion is when the patient does it when the examiner has to do it completely and there's nothing for the patient is doing. I have to tell you that passive range of motion is usually greater than active range of motion. And why is that? Because the arm is relaxed, there's no muscle input, there's no soft tissue restrictions, etc. So passive range of motion will be greater than active range of motion. An end feel. An end feel is the resistance that's felt when a joint reaches the end range with passive movement. Okay, so if you take the limb into full passive movement at the end range, there's a slight resistance that's normal in everybody, and that's known as our end feels. Okay, and this takes time to learn and time to feel. So the end range is reached before the physiological end range. So when we're going to talk about end feels, we're going to talk about two types of end feels, normal and abnormal. We see that they look similar. I mean, they look pretty much the same, right? A normal end feel can either be soft, firm, or hard. An abnormal end feel can either be soft, firm, hard, and also can be empty, which we'll talk about in 1 second. So a soft end feel is that contact between some kind of soft tissue, right? So soft tissue approximation. Example is knee and elbow flexion. So we have soft tissue that we could feel at the end of our motion. So if we take our elbow, if we take our knee and we passively flex it, and we can apply a little overpressure and feel some kind of a restriction to passive movement, it's soft. A firm end feel is more like a stretch. So it's a muscular, capsular, and ligamentous. Example of that is ankle dorsiflexion, finger extension. So if you all sit there and just take your second fingers and extend your finger, you feel that when you go to the end range, so passively extend your finger and you push through it a little more, you feel a restriction that's muscular, capsular, or ligamentous. So that's a firm end feel. That's forearm, internal rotation of the hip, finger extension. A hard end feel is one where it's bone on bone. So the bone contacts the bone. If you do elbow extension, you're getting to a point where the bone is restricting you. You can't go any further, except for those people who are hyperextended. And if those people are hyperextended, we don't want to push them into hyperextension, as well as the knee. We don't want to pull the knee into hyperextension. That we would have to document the end feel is abnormal because of the hyperextension associated with that joint. Okay, so hard end feel. Abnormal end feels, soft end feel. Soft end feel occurs sooner or later, and you'll see this for every one of these, occur sooner or later in the range of motion than usual in the joint with normally firm or hard end feel. It feels boggy. So boggy is usually something more like, when we talk about something that's boggy, we say it's edematous. It feels boggy. Soft tissue edema, synovitis, ligament instability. That's when you have a soft end feel. That's abnormal. Firm end feel occurs sooner or later in the range of motion of the joint that normally has a soft or a hard end feel. So example, capsule is limiting you, the muscles limiting you, the ligament, fascia, it's shortened. We have an increase in muscle tone. So because of that, we have an abnormally firm end feel. Hard end feel occurs sooner or later in the motion, and it's a bony block. So if there's something stuck in the joint, so OA, let's just say for a knee, so we're going to bend the knee and we can't bend any further. Somebody who's got sickle cell anemia, some pathology. There's a loose body in the joint, myositis ossificans, a fracture, an osteophyte. You can't go to the full range of motion because you're stuck. It's a bony end feel. And then an empty end feel. An empty end feel is associated with someone who is stopping you from moving them because they know they're going to experience pain. So it's more protective in nature. So the patient splints, or they have a muscle spasm, or they just stop you. They say, "Oh, no, don't do that." Okay, so that was known as an empty end feel. So somebody who has acute joint inflammation, an abscess, a bursitis. Or it just may be psychological. Okay, very
So
rare.
would an empty end field be related to, say, muscle guarding?
Is the end field associated with what?
Muscle guarding.
Muscle guarding, yes. Yes. So the patient will stop you. Patient stops you before you can get to the end field. So that's known as an empty end field. What's hypomobility versus hypomobility? Hypomobility is decrease in range of motion. So who would have hypomobility? Some orthopedic conditions can have hypomobility. OA patients have hypomobility. RA patients have hypomobility. Somebody who has adhesive capsulitis, scars, burns, spinal disorders, you know, and anybody like that. Head trauma, you may see hypermobility. Any type of hypermobility, increased tone, spasticity, then you'll have hypomobile joints. Hypermobility refers to an increase in passive range of motion. So remember we said the other day, there's somebody who can have hypermobility syndrome, but we also said the other day, does anybody remember from the acquired systemic diseases, somebody who might have hypermobility? Marfan syndrome, right? Marfan syndrome. There's also something,
And Down syndrome as well.
Down syndrome, right? There's also something known as Ehlers-Danlos syndrome, Ehlers-Danlos, where you have hypermobility, ligament laxity, hypermobility. Okay, osteogenesis imperfecta, Down syndrome. These people all have hypermobility. Okay. Factors that affect range of motion. Do children have more range of motion than adults? I would say so, right? So kids have greater range of motion than adults. Does range of motion decrease as we age? With some people it does. Does range of motion decrease with muscle girth and muscle bulk? Yeah, probably. So if somebody is a weightlifter, they may have a decrease in range of motion. If somebody is just obese, they can have a decrease in range of motion. Does gender affect range of motion? Yes, gender affects range of motion. Women usually have greater range of motion than men, secondary to hormones and ligament laxity. Body mass index, we just said. Occupation. If you're a painter, are you going to have more range of motion and extension? You're painting a ceiling all day than flexion? Yes. If you're going to be, if you're playing a lot of baseball, I think about Dave. Dave was a catcher, right? Is he going to have more range of motion or more rotation on the right side than the left? Yes. Does that mean he's probably going to have, which we haven't looked at, but does that mean he's probably going to have some tightness of those external obliques and some lengthening of the internal obliques? Probably, right? So those recreational activities. Positioning, passive insufficiency. We already know what passive insufficiency is. And as well as inadequate stabilization. Okay. You want to put the arm in neutral to measure the biceps because if the shoulder is flexed. If shoulder is in flexion and you want to measure flexion of the elbow, the triceps can be eliminating your motion. So if your arm, your shoulder needs to be in neutral to measure flexion of the elbow, because if I flex the shoulder and flex the elbow, I can have passive insufficiency, and because the triceps is limiting my motion, is limiting, not eliminating, is limiting my motion. You guys know what passive insufficiency is. Okay, inclinometers versus goniometers. An inclinometer is something that you just place on a patient, and we do have these also, and you ask the patient to move and it gives you a reading. And goniometers have three different things, three parts associated with it that we'll talk about. So it has an axis or a body or a fulcrum. It has a stationary arm, which is part of the structural part of the goniometer, and then we have a movable arm. They can be half circle goniometers, full circle goniometers. They can have two scales, 0 to 180 or 180 to 0. You need to be consistent with whatever scale you use. and some full circle goniometers go to 360. Okay, so when we look at a goniometer, we just need to be consistent with our measurements. So what do we do when we look at range of motion? We always want to have the patient perform the range of motion actively so that we could see what their range of motion is. Put the patient in the appropriate start position, stabilize the proximal joint, move the distal joint to 0, move the distal joint to the end range of motion to determine the end field. So you're doing that passively. You return to the start position. We want to palpate whatever landmarks we're going to use. Stabilize proximally, move distally. So you're going to align the goniometer to the proximal and distal parts, and you're going to move that distal joint. You're going to read the goniometer, and you're going to record the range of motion. So normally, let's just say elbow range of motion is from 0 to 150, and we're going to have to learn what's normal and what's abnormal. But normal range of motion of the elbow is 0 to 150. Abnormal range of motion can be 20 to 0 to 150. 50 to 150 is 100 degrees of movement. 30 to 130 is 100 degrees of movement. Can anybody tell me, Casey, I guess because I could hear you very well, can you tell me the difference between this and this and this? If you could say no.
I can't really explain it now. I
Okay.
mean, I know there's
Andrew.
limitations.
Andrew, can you tell me the difference?
He says yes.
You can. All right. So you want to tell it? You want to tell everybody? No, you don't? Devin?
Good try. Okay. Hello.
Yes.
There could be like a possible contracture that's making the elbow start at like 20
That's
degrees.
not Devin and it's not Andrew. That's Rod Neal, right? Right?
Yeah.
Yeah. All right. So let's look at the first one. That's abnormal, right? 20 to 0 to 150. If I'm saying this is normal, 0 to 150, then this has got to be abnormal. And this has got to be abnormal. And this has got to be abnormal, right? So what is this indicating?
Is that 20 degrees hyperextension?
Yes.
So that would be like my elbow where it's going in, it has extra 20 degrees of hyperextension.
So
0 is
20, yes. So 20 indicates hyperextension. 20 to 0 to 150 indicates hyperextension. So there are certain people in the class that probably have 10, maybe 15, and I know that because they just have a lot of flexibility. So that's hyperextension of the elbow. 50 to 150 and 30 to 130, they're still 100 degrees of movement, but how are they different? How are they different? They're different because this one has normal end range of motion, but not normal beginning range of motion. This one has neither normal beginning or normal end range of motion. Okay, they both have 100 degrees, but this one is starting at 50, may have a flexion contracture at 50. However, can go to 150, so can go through its full range of motion, but starts at 50 degrees. This one starts at 30 degrees and can only go to 130 degrees. So we have limitation of motions here at the beginning and end range of motion. And that's what this means. So when you look at these, you need to understand what it says, because if you go into a room to work with a patient and this is normal, this is abnormal, you got to already figure out what does that patient look like before I even get in the room. Okay, so that's an abnormal range of motion. The other thing we need to know when we look at range of motion is we need to know reliability. What's the reliability and what's the validity? Okay, so is it reliable? The reliability is associated with the reproducibility. The validity is does the goniometer or does anything do what it says it's going to do? So if you're using a goniometer, does the goniometer do what it purports to measure? Does it measure what it's supposed to measure? And the validity on the goniometer is very high, as long as it's reliable. Now, the reliability, as I said, is the reproducibility. So what's the difference between an inter-tester and an intra-tester? Inter-tester means that Andrew measures the range of motion prior to the therapeutic intervention. Then Devin comes in after the therapeutic intervention and measures. Now, before the intervention, Andrew got 50 to 130. After the intervention, Devin got 60 to 120. Does that make sense? No, it doesn't make sense at all. Should be that after the intervention, it gets better. It got worse. So either Devin or Andrew doesn't know how to measure. Okay. So inter-testers mean that it's the measurements between testers as opposed to within testers. An intra-tester is the same person is going to test before and after. And when does inter-tester, sometimes intra-testers are okay, and inter-testers can be okay if somebody's got a lot of experience. Well, the reason why I said there might be a big difference between Devin and Andrew is because you guys are new. It's the first time you're doing it. So there are going to be some differences because maybe the landmarks were inappropriate. Okay. When we do measurements, we have to know what landmarks we're using in order to make sure that we have reproducibility. So in your books, and also I've included in this handout, where the stable arm, where the axis of the goniometer goes, where the stable arm goes, where the movable arm goes. Because usually the stable arm, let's just say we're measuring hip flexion and we're using the greater trochanter as the landmark for the axis. And the stable arm is in line with the trunk, perpendicular to the trunk, in line with the trunk. And the movable arm is perpendicular to the femur, in line with the lateral condyle, and in line with the longitudinal axis of the femur. You're going to have to say that because that's where those landmarks are. And then as the limb moves, you're going to have to follow the, when you do passive flexion of the hip, you're going to have to stabilize the goniometer so that you can follow the movable arm in line with the lateral femoral condyle so that you accurately report the range of motion of hip flexion. Okay, so it sounds like it's easy. It's not really that hard, but it takes a lot of practice. Okay, so there's reliability and there's validity associated with the measurement of the goniometer. Okay, and so we could see here that the action is flexion. So the axis would be on the lateral aspect of the greater tubercle, and some books say an inch below the acromion, so greater tubercle acromion. The movable arm is the lateral midline of the humerus. We're using the lateral epicondyle as a reference. Stationary arm is parallel to the mid-axillary line of the thorax, in line with the trunk. Normal range of motion is 180 degrees. We're going to measure in supine, and the end feel is firm. Okay, because we're talking about capsule, we're talking about ligaments, firm end feel. Okay, so we will do the shoulder, we will do the elbow, we will do the hand this morning. And as I said, you also have a book, Measurement of Joint Motion. So you could look everything up in that book. And I also have some other information I could share with you that some students had put together in the past regarding goniometric motion. Okay, so we'll take like a 15-minute break and then we'll meet and we'll start doing this. We'll also go over all the gait, because next week we have a gait practical as well as a gate exam. So we'll go over some of that this morning also. Okay.
Is it next week or is it the 26th, 28th?
Was it next week? I don't know. I don't remember. Did
I believe
anybody?
you said the 26th, 28th.
26th, 28th is the gate practical? All right. Okay, if that's what I said, that's fine. I'm glad you guys kept it, because I don't have it in front of me right now. I'd have to look it up.
No
But
worries.
if that's it, that's fine. But I know some of you will have to practice some gate today. We could do that, and others can practice goniometry, and then we could switch, because we have a lot of time, and I allotted a lot of time for that, because I know we need a lot of time with goniometry, and then we're going to do manual muscle testing. So we're going to start goniometry today. You guys all have your goniometers, I hope, and we'll go over all gate also, and we'll wait for the other guys to come in. Does anybody need help with gate? Nobody's saying anything.
There's a few people who were nodding their head, so yeah, I think
Okay.
so.
All right, so let's end this and then take 10, 15 minutes, take a little break, go to the bathroom, whatever, and then we'll meet back in the class, okay?
Sounds good. Thank you.